Good evening, ladies and gentlemen. I'm your host, Munson Steed, and welcome to Health IQ, sponsored by AARP. It is important that we actually have access to information. Fake news pervades as it relates to health, and we want to eliminate some of these and many of the ridiculousness that's actually going on in our community. We have to depend on the facts. We have brought the fact, the science. Stick with science. Bleach will not help you. Believe me. So I don't want you to imagine that. The other thing is there are a lot more options. And today it's all about options. You may not consider telemedicine an option, but after this discussion, we hope that once you've spoken to the doctors, once you've spoken to the public health experts, that you will trust telemedicine in a way that you never have before. So I've got a great panel. Phenomenal professionals dedicated to sharing and eliminating health disparities and serving our community. So, Dr. Clarissa Colbert, famous author for all of you who didn't know, so support her and grab her book, but she's in New York. Just kidding, she's in a little small state of Mexico. So there are sisters in New Mexico. But right. Telemedicine means that she can help you anywhere in the world. But I love that. Dr. McDougall, congratulations. He is the new president.
Thank you.
The new president, you were supposed to help me. I dropped the mic.
Of the National Medical Association, representing the collective voice of over 45,000 African-American physicians and our patients.
See, I told you guys we're bringing something special here. It's a real important. So, if you've never been to Flint, you should definitely knock on her door and say hello. There's not a more dedicated person to understanding, and we want those who aspire to be in the sciences. And you might think about med school, but you aren't quite there, and you like the science, and you want to serve and find and be that detective that we are so dependent and don't know it. But we need cultural lens. I would like to say that even though I haven't met her in person, she's been a supporter of Health IQ and rolling out, that she is determined to make a difference in the health and the delivery of our community. Dr. Deborah Fur Holden.
Hey.
Come on down. So obviously we've got a whole lot to talk about in a little bit of time. Dr. McDougall, if you don't mind, I'll let the ladies go first and then we'll come back around to you. A simple kind of housekeeping idea of how should we approach telemedicine as a community? Dr. Colbert.
So telemedicine is something that I think many of us had not experienced pre-COVID. You know, I think many of us did not anticipate that we would be in a pandemic, right? Think how 2019 ended. 2020 was our year. We were going to make things happen. We were going to see changes in the White House and all these other things. And then here we are. And so I myself have become a consumer of telemedicine. I had never had a telemedicine appointment before the COVID pandemic. And I'll tell you from a public health perspective, this is vital. We've already had gaps in healthcare services, and our people, specifically Black and brown people, getting their needs met. And one of the things that we know is happening during the COVID pandemic is everything else has moved forward. Chronic diseases are cropping up. People are stroking out. People are having cardiovascular illness. New illnesses are cropping up. And telemedicine has become a primary vehicle for us because one of the mandates that happened during COVID is primary and preventive care got shut down in person. And so telemedicine is something that I know seems strange, right? We're used to seeing the doctor in person, but we have to use all of the resources that are available to us because the health of African Americans is hinged upon us being able to access the healthcare system. So I think telemedicine is more important now than ever, especially for Black and brown people.
Thank you. Dr. Colbert?
No, I completely agree and echo the same sentiments. I think the thing that I would add, my field is specifically in diagnostics. And so I work in a diagnostic testing lab. And that's one of the challenges that we face as the in-person outpatient and hospital visits have decreased and we've shifted to telemedicine. There's still a need for people to have blood work done and have the laboratory tests that are affiliated with the diagnostic testing. So having avenues that we can get diagnostic tests to providers, but also having ways that we can explore more home testing options for patients becomes an added tool to telemedicine. So it's not just the doctor's visit at home, but having home testing options and home testing resources so that we can help to keep people safe during this pandemic, but even beyond. I think one of the challenges we have to continue to consider is the technology disparity that really impacts the delivery of telemedicine. We experience that especially here in New Mexico, where we have a large proportion of people that don't have access, ready access to high-speed internet service and strong telecommunication services. So those start to just highlight new disparities that we have to continue to fight in all areas of healthcare.
That's my long pause. Just so that everybody knows. Dr. McDougall, if you would, please, sir.
Okay, so I think it's important for us to distinguish between low-tech telemedicine or telehealth and higher-tech telemedicine. So I've been patients on the Near East Side of Columbus for the past 18 years. Most of my patients are older, and some may not be adequately versed in using computer technology or even smartphones. So with me having an established relationship with them already, we have an electronic medical record, which I have access to.
Yeah, me too.
I think Dr. McDougall got some Boost mobile Wi-Fi at home or something. I joke him a lot. I can't help it. You were breaking up, Dr. McDougall.
Okay, am I back? I'm
Yes.
not certain why it broke up. So thank you for that. So there's a low-tech version of telehealth and a high. So people and patients that I have already established a relationship with, I'm looking at my record, the medical record. I actually call them on the phone and talk with them and go over their health maintenance and issues that we have discussed and during an in-person visit. So you may not necessarily need the highest tech version with visual to be able to communicate and provide care. Now, those patients who are more technically savvy, who have internet access, have home computers or a smartphone, then we can add the visual component, and the funding or the is where we're cut off again. The appointment is where a picture is used. Actually, we can bill the same as an in-person visit. So from my point of view, then yes, there's the higher tech version of telehealth or telemedicine. We can still, as a primary care physician, I can still accomplish most of what I need to do, even if it's a telephone and me looking at the electronic medical record and having their medications and their blood pressure. And this is where it helps if insurance would help for home blood pressure monitors with large cuffs, because a number of patients are overweight and they need the larger cuff to get a accurate blood pressure reading. Nearly all of our persons who have diabetes already have a home glucometer. So most of my patients have diabetes, and so having interim visits helpful, especially for those patients who have transportation challenges, which is very common. In our health system, to give an example, so in March, we went from having about 50 telehealth visits in a month to now 2,500 telehealth visits in one day. So that's the transition that has occurred. I'm just trying to get across to you that when these discussions take place, it always seems like people are talking about the highest levels of technology being needed to communicate with one's patient, and that's not necessarily so.
Okay, I can understand that. I think that's a real observation that we need to consider as we move forward, that people at least call their physician, and we're considering that the low tech. The high tech, obviously, I think for a lot of seniors, obviously they don't have the capacity to really understand their something beyond a flip phone, and they're having to grow in that area. So I think there's just outreach and training that we probably want to do, maybe at churches, to get people used to even dialing in. And I do think the use of community services and places that they can get more support for their health in general, like a church on Sunday, so that we can provide that. You wanted to say something, Dr. Holder?
Yeah, because the thing that I tell people is a lot of what we're seeing and the gaps and the weak spots in our healthcare system, specifically as they affect socially vulnerable, ethnic minorities, people with financial challenges, or the elderly. All of this stuff predated COVID. You know, so when you hear Dr. McDougall talk about going through the electronic medical record and having a phone call with the patient because they have transportation issues, et cetera, well, nothing happened in COVID that gave people transportation issues per se. Transportation has always been a barrier to people getting testing, to people seeing their physician, to people getting that in-person care. So the thing that I always remind people of is what we're dealing with right now in COVID gives us an opportunity to take that critical look at ourselves, how we deliver care, how we've left certain people out of care, how we've been okay with knowing that a lot of people have these barriers and brought zero to very little innovation to trying to solve these problems. COVID has sort of forced us to do it. And my hope is that what we learned during COVID is something that we can ideally sustain beyond COVID, because if we were able to do that, we could actually help to narrow that gap in what we call these healthcare disparities. So it's about COVID, but there's an opportunity afoot to do something beyond COVID.
Dr. Colbreth, what's the opportunity beyond COVID?
No, I mean, I completely agree. I think all of these things could have happened prior to COVID. Some of the barriers that COVID helped to bring down had to do with the payment models and the structures that were in place for insurance companies to be able to bill and for the telehealth visits to be covered by insurance so that individuals didn't have to pay extra for a telehealth visit. That removing that barrier has made telemedicine more accessible. I think what we need to continue to identify, as I mentioned a little bit earlier, is on the diagnostic side, there is still a need for people to go in and get blood work. There's kind of a statistic that's out there, a loose statistic will say that 70% of diagnostic decisions are based on a laboratory test. Yeah, it could be anywhere between 50 and 70%. But if you look at any of the clinical guidelines for management and diagnosis of diseases, whether it's diabetes, HIV, hepatitis C, any disease diagnosis, 80% of the guideline is based on a laboratory test. And so what we really need beyond COVID is more innovation in access to home specimen collection, home diagnostic tools, so that we can continue to remove and eliminate some of these barriers to patients being able to receive access to care. If we think about something like diabetes diagnosis and monitoring, you have to have a hemoglobin A1C, a glucose tolerance test, a fasting glucose. These are all laboratory tests that will aid in the diagnosis and management. So patients still have to get to a place to get a lab specimen collected. Unfortunately, during COVID, we saw a number of laboratory visits also decline. So we have patients who weren't getting appropriate monitoring, and it's time for us to go back and identify the patients who've missed some of those crucial monitoring tests that would help to give insight into the phone visit that Dr. McDougall would be having.
So can I speak to that? So what we've been doing then, at least I've been doing, so with the phone visits, putting an order into the where you're checking their creatinine for their kidneys and their potassium once a year, and then provide a window for that patient to come into just to the lab to have that testing done, and then me communicating with that person after the results are in regards to actually making diagnoses in regards to diabetes. That's something that's I think would be a bit more difficult to do, mostly in that outpatient setting. Is more so for me, it's been with established patients, but if needed to do that, we could enter an order into the computer to have a 2-hour thing or 2-hour glucose tolerance test done, or fasting glucose is what I typically would order initially. So so telehealth, telemedicine is here to stay. It has added a lot of flexibility how we manage patients, especially from an outpatient setting. And I think there will be an opportunity for home health services that include test health services paid for by Medicare or Medicaid, because they difficulties. So
Dr. Holden?
I think about, and I don't think innovation is going to come because we asked for it. I think we're going to have to push for it. I feel like a revolution is needed in the healthcare system. I think about the innovation that we have already and where it came from. I can give my children, and I have, a home-based drug test. I submitted a DNA sample for Ancestry. I spit in a tube, and 2 weeks later, I found out I was 46% Nigerian. There is all kinds of innovation that is available to us. The problem is the people who primarily need it and who would be the beneficiaries of it don't wield the kind of political power. We live in a society, unfortunately, where we have a hierarchy that we've placed on the value of human life. Mm-hmm. And the life of poor people, and typically the Black and brown people, is lower on that hierarchy. So I feel like what's needed is really a healthcare revolution. And I know, I don't know if Dr. McDougall already pointed to this, but he was doing telemedicine pre-COVID. He was already doing telemedicine because he knows, as a physician at the Ohio State, that that's a need in the community and with the population that he serves. So I think we need a healthcare revolution. I agree with Dr. Colbert that a lot of the barriers around billing and insurance codes and all of that have by necessity been removed during COVID. But this is a revolution. The insurance companies didn't do that because it was the right thing to do. They did it because if they didn't, they wouldn't be able to get services that could then be billed, and the system of how income gets generated would have been shut down. They didn't do it because it was the right thing to do. They did it because the pandemic sort of forced their hand. So I think the thing that we need to do is continue to force that hand even beyond COVID. We have to force the innovation. I don't think it's just going to come naturally.
You shake your head like you agree, Dr. Colbert. I mean,
Yeah, no, most definitely. I mean, none of these technologies are brand new. There have been telehealth platforms that have existed. There have just been barriers. And we say barriers as if there was a reason, a barrier that prevented it. It was just a financial barrier and a barrier of will and desire. The things that I also think about around innovation, right, is the things that we all have. Almost everybody has a Fitbit or an Apple Watch or some type of wearable technology. So I think as we start to think about how do we integrate this digital age into our healthcare and allow for the patients to take more ownership of their healthcare. That's something that we can start to look at innovations in the wearable technologies to be able to have, active communication between your Fitbit and your electronic medical record about your blood pressure, about your heart rate, that all of that information is more actively happening rather than having to stop and take it and you start to have compliance issues with the patients. But all of that is part of this revolution that's necessary, where patients really begin to take ownership and take back ownership of their health data, of how they're able to manage their own health with the information that they have and they provide to their healthcare providers. So the whole system really has to be shaken up.
And I'll just jump in, this notion about seniors, having been the primary caregiver for all of my grandparents and parents, I took them to those appointments. I was the translator between the doctor or the physician or the physician assistant and my stepfather and my mom, right? The notion that it's a barrier that the sort of integration of technology and medicine can't be accomplished. Well, primary caregivers for our seniors are already towing the line and doing the work, and it comes at a cost. I couldn't count up the number of hours that I missed from work or school or whatever to make sure that the needs of the seniors in my family were taken care of. It would have been substantially easier for me to facilitate a telehealth appointment. It would have been substantially easier for me to support making sure there was technology in the home that I could walk them through. My mom was not a very tech savvy person, but when she broke her leg and wasn't able to leave the house, she surely was happy to have me give her a laptop and show her how she could play Keno at home on the laptop. And she figured it out real fast. So I just want us to be also mindful that as we identify what some of the barriers are and maybe some of the gaps and some of the challenges, that we also balance that out by looking at the realities of what the system currently is and not let those be the thing that stops us, but be the thing that challenges us to be more creative and innovative in then the solutions that we build. Because we're already figuring out solutions to make sure that our seniors and our most vulnerable are taken care of. This is about adding and expanding that tool belt of possibilities and options, and we deserve that.
Yeah, most certainly. If we think about the amount of time that it takes when you have somebody who has perhaps a limited amount of time for a lunch break or having to pick up a child and take them to a doctor's office, and the time spent in the waiting room, that's one of the number one complaints from patients is the amount of time that they spend in a waiting room. I've had telehealth visits with my daughter. They give us a notification 5 minutes before the provider needs us to jump on. And so instead of a 20-minute wait in the waiting room plus the travel time, it was a 5-minute wait, in the Zoom or whatever platform it was, waiting room, to have that visit. So that starts to really benefit the people that might have very limited time for breaks and who are caretakers of other family members.
Yeah. As many barriers, there are opportunities.
And based on some of the research we've done here, older African Americans are receptive to technology. So it is not a given to assume that older Black folks don't want to use technology. Not so. My patient, he's like 75-year-old retired barber. He's got the latest technology, using it to communicate showing me these smartphones and everything. And so it's not, so don't make that assumption.
I don't know who made that assumption. My mother's 87 years old. So she is on YouTube watching me in the morning. I think the whole idea, doctor, though, is, the question is very much for Dr. Holden as it relates to the real, revolution. I think it's great to see you, and I look forward, and I hope the entire Black community knows your name, because we really have to have soldiers like you who are willing to really give us an idea of loving our parents, loving those elders and seniors in the capacity that, it took her 2 hours to kind of feel comfortable hopping on and pushing that app. And she didn't know why I wanted her to have an iPhone. And I was like, I want to FaceTime you so I can see you right then. And, after a struggle and trying to get her to see my position, she finally decided, okay, I will. And now she enjoys it. So I don't think there's an assumption. I think outreach to our community and making that a cultural priority in everything that we say. I'm not sure that we have Cardi B right now saying that. I'm not sure that Offset or 2 Chainz really have met with you so that the individuals who are disseminating critical information to our community are necessarily doing that in a way that elevates this conversation to where we could see some real healing and new methodologies coming forward.
And I'll tell you, having gone through burying 3 aunts in 3 weeks during COVID, I had an aunt die every week for 3 weeks from the end of April to the second week of May. All of them, my one aunt, we sat with her on a FaceTime because they wouldn't let us in the hospital. I almost feel like if you balance out, and don't get me wrong, I put the highest accountability on the institution and the system, but there is something that people can do that's in their own hands, right? And you'd rather do it now, because when it becomes a necessity, you might not have the opportunity for the learning that has to happen for you to allow people to experience their life and their health with dignity, and also their transition and their passing. We are in a season that, unless you've had to lose a loved one or bury somebody during the season, you can't imagine what it's like when our family tradition is we are all at the bedside. The ancestors are there. The ones who passed on are there in spirit. And how I know is the ones that are passing on start saying their name. And you think they're confusing you for them. No, the ancestors are there with them. But during this season, we haven't been able to be there physically because we're not allowed to be in the hospital. So this need to help the elders and the seniors bridge that technology gap, it's critical. People should be able to live and die with honor and dignity. So people having access to these tools and us forcing the innovation, I think COVID has just given us the opportunity, but it is something that I think is long overdue. And I would not wish that on anybody, to have to die alone in a hospital room without the physical presence of your loved ones around you. And we need to prevent and avoid that. And telemedicine is not the end all be all, but it is such long overdue tool that we need to add to this tool belt. And again, it's a revolution. We're going to have to force this. It's not going to happen because it's the right thing to do.
I'd like to add to mentioned about death in the hospital, and my condolences are extended to you and your family. So advanced directives, African Americans, Black families are less likely to complete advanced directives. So when there's this COVID-19 epidemic, pandemic, and there's restrictions on visitors, perhaps no visitors, who's going to represent the wishes of your loved one? So to have that advanced directive available so that someone else is not making the decision for your loved one, or that it is at least informed, because we're aware of do not resuscitate orders being involuntarily enacted by people who are rationing scarce resources. So that just reminded.
Dr. McDougall paused, but him and I, we have both talked about this issue. I think he's back. I don't want to speak for you, but Dr. McDougall, you just broke up. Just so people are clear, a DNR, do not resuscitate order, is when you say, I do not want life-saving measures to be implemented should I go into a critical condition. And typically, if you look at what the data tell us, African Americans are substantially less likely to endorse those types of orders. We have to me, valid and well-earned mistrust of the medical system. So we don't trust that people will actually be acting on our best behalf. So we say, no, do everything you can to save my life, right? We typically, pre-COVID, have had a substantially lower rate of do not resuscitate orders. We want those life-saving measures. What we've seen during COVID is that there's been a little bit of an uptick in that. And people are, because family members and people who would normally make decisions are not at the bedside, are not in the hospital, those decisions are being made by medical personnel, oftentimes who are faced with tough decisions themselves and trying to ration resources. You know, we learned early on in COVID that people have to make decisions. If the hospital has 20 ventilators, which 20 patients are going to get that? Are you going to give it to the 65-year-old African-American male with hypertension and COPD and the like, or are you going to give it to a 30-year-old, patient who has asthma and got COVID and is having trouble breathing? People are betting on the odds and gambling on the odds, but prioritizing care that way puts us in harm's way of being further marginalized in the healthcare system. So again, this use of technology, how we integrate telemedicine, and also how we include families and caregivers is critical. It's especially critical during COVID, and the opportunity is to get this thing right and figured out so that the benefits of what we learn and implement live beyond COVID. You know, nobody really talked about everything that they said around why are African Americans disproportionately impacted by COVID. The thing that people pointed to was pre-existing health conditions. That only explains about 10% of the disparity. It definitely didn't explain the death disparity. But when we start unpacking and looking at some of these other social political determinants of health, things like how we get treated in the healthcare system, things like the fact that our pre-existing health conditions had us be prioritized lower on the continuum of care for these critical decisions around what patients got what, then you start to account for a much larger percentage of the disparity that we saw during COVID. I hope that made sense. I know that's probably a lot, but it's a critical thing. And I really hope that your listeners will elevate and heighten their own awareness. You think about it. A lot of us go and see our loved ones in the hospital because that's what we do, but we're also checking. You're also looking to see, is grandma being taken care of? Is grandma clean? How does grandma's nurse interact with her? Well, all of the things that we normally do that elevates the care that our loved ones receive, we're not able to do that during the season because oftentimes nobody is allowed in the hospital besides the patient. So Dr. McDougall, I didn't mean to talk over you, but you broke up and went silent, so I didn't want that point to get lost.
So that durable power of attorney for health and living wills did a job of filling out those documents, and that's low tech.
Yeah.
You're on the low tech today, Dr. McDougall. No, I love it. I love it. I love it. But I love the idea of diagnostics and the revolution that has to take place there. What would you suggest, Dr. Colbert, that we advocate for that isn't in place right now?
Right. So, some of the things that I've mentioned, really exploring, one is having more access to care. right? And as Dr. Fulholton was mentioning, some of the challenges and the healthcare disparities that we saw in our communities and that we currently see in our communities that have impacted the infection rates of COVID, but then also the death rates, have stemmed from access to care. And so telemedicine starts to improve access. And if we can have better access to care and better management of our chronic conditions, then we are set up for better outcomes for many diseases, including COVID. But I think as we look at diagnostics, we have to continue to advocate for better diagnostics, but improved access to diagnostics. And I really believe in patients being able to help to drive some of their own healthcare decisions and their own healthcare management. Some of this can happen through at-home diagnostic testing. It can happen through innovation and being able to utilize wearable technologies that patients would be able to have better communication. As we were talking about the older people and older adults involved in their own healthcare, my grandmother has her My Chart open after every visit, and she's going through and looking at her own laboratory values, and she's looking through everything and asking me, okay, well, what does this mean? How this one went up and this one went down. So patients having more access through technology is a positive thing, and that helps for patients and their caregivers to be able to have more ownership and to be able to call the provider when they see something, a lab value that might have gone up or gone down, and have some more communication. I think we have to move from healthcare only existing with the provider, that we're all involved in our own healthcare. And so it really is a partnership. I have to do my part, the provider does their part, but if we can have more communication where we are all communicating at the same level on the same things, I think it's better for everybody.
Mm-hmm.
Not certain. I think Dr. Holden and I were probably going on maybe session 10, and I've probably interviewed, there's 3 here, let's just say 2, so maybe 20 physicians. I've asked everyone I asked about the revolution, and I heard Dr. Holden, but I'm mainly concerned, and this is for you, Dr. McDougall, about, and you mentioned it, Dr. Colbreth, the real truth that we all want to know about our health. I'm afraid that maybe even the devices need to be issued so that they can do some real active, but it seems like we don't have good KPIs, and those that we do have, we're ignoring. And I'm a little concerned about that. I've noticed, because I'm here stuck, because I talk to epidemiologists, so that doesn't allow me to leave my house. After I talk to them, I'm like, they gotta stay home. I'm gonna miss the parking lot party. I'm gonna miss the drive-in party, because I haven't seen a drive-in party or parking lot party where anybody stayed in the car. So I gotta pass on that. It just hasn't happened. But I'm afraid that without your help, and that's all of you, that there's no place, Dr. McDougall, where we can literally see the key performance indicators as it relates to health on the minds, the lips, and our entire community. And I'm a little upset because COVID was at least a moment to reset your whole program. How can we do that through telemedicine, obviously through the devices, so that individuals really can take better care of themselves and be a part, not just the physician? Because I love my physician, but I don't really want to go to him other than to get the insights, the knowledge, and I need to take a more active role in my own health. I mean, I didn't make sure that I did 20,000 steps a day just to because I love running that much. I mean, I'm vain, but not that vain. And I didn't read my Fitbit because I read it because it was necessary, not necessarily that I wanted to. How do we change that behavior with telemedicine and with the devices and diagnostics? Dr. McDougall?
A link to a healthcare professional. And for African Americans, especially having an African American physician or provider, you're more likely to listen to me. I'm more likely to listen to you. So we can negotiate a plan. Every
You gonna finish that sentence, Dr. Holder?
needs to have a primary care, and therefore the technology can be used as a bridge to better health.
I'm going to say this one more time, but I'm going to let Dr. Colbreth speak.
You know, I really appreciate Dr. McDougall's comment about being able to have access to an African American provider because I live in New Mexico. And I don't think anybody has to guess how difficult it may be for me to find an African American provider. And so one of the things that telemedicine begins to open up is access to wider networks, potentially of providers, potentially being able to have more access to other types of providers. We've talked mostly about physical health here, but mental health has also opened up for telemedicine. And there's been more opportunities for mental health to occur, especially during these times where people are really experiencing levels of crisis that have been added to because of and multiplied because of COVID. So telemedicine begins to open up access to other providers that somebody may not have been able to have access to in the past, whether or not it's between as a healthcare provider or a mental health professional. And I think the other thing that telemedicine adds is more communications between providers. One thing that we do have here in New Mexico, because we're such a rural state, and there's some providers that are out in a rural area and don't often have access to the specialists that are in the city, is we have some telecommunications between providers so that primary care providers can discuss patients that are experiencing and need specialist level care, and they can have more communication about those patients through programs that we have here in the state. So there's a lot of layers to telemedicine that's really about access to the right providers for the right patients to meet their specific needs.
Yeah, I'm still lost on the crises that you were defining during that moment. Still a little nervous because I'm not sure we're reset, Dr. McDougall. I'm definitely with Sister Holden over here on the revolution. I really want to see that manifesto. But I think if we don't come out of this with the health manifesto and really a new health language that we're able to communicate to our community, Dr. McDougall, we're going to be in a bind because we know everybody else is over on the profit side. And we really want our community to take better charge of, how to reduce your blood pressure, how to deal with the diabetes so that, losing weight is a part of your regimen that just is taking control of your health versus something you have to do.
Now, talked about racism, and at our institution, we're developing an anti-racism campaign in regards to what's driving these disparities in healthcare and how will unity, and that's part of the solution. Also, increase American Black healthcare professionals. That's pressure that we need to institutions and to help provide more advocating for in the manifesto and the National Medical Association. So moving forward, collaborating with others, and looking at health equity, which Dr. Fur Holden is the national expert on, and versus perhaps what we kind of tend to do now is just look at the individual patient level. Let's look at the community. Let's treat the community and have measures that allow us to take action. Because high blood pressure is what's killing Black people. High public I'm breaking.
Yeah. And we miss you when you're gone too.
Am I back?
You're back.
Okay. So
You're gonna owe me a repeat after this.
okay, I'm not certain what's happening. You know, I'm right next to the transponder or whatever. So I'm doing.
Yeah. Now you're gonna owe me a redo because this
okay.
Is and
yeah. So yes,
it's killing our community. That's kind of where we left off. What would you think the 3 things we need to do to address that?
So diet, decreasing the salt. Moving towards a plant-based diet, eating more fruits and vegetables is the various markets to buy soybean products and the like. There's a high, you may be eating more vegetables, but look at that can and the sodium is so high, it's increasing your blood pressure. I know for me, it's hard to find and hard to really comply with a lower sodium diet because everything has sodium in it. So you do have to eat more fruits and vegetables and fresh fruits and vegetables, and that makes it more difficult for persons who may not be living near an open market or a grocery store. So there's some systemic barrier process and what's available to us. And then having those medications prescribed to bring one's blood pressure down. Because when you look at, for instance, death related to alcohol and death related to drugs, European Americans have a higher death rate than African Americans. Age-adjusted death in regards to smoking is about the same, about 17%. So those things are what's killing us, is our diet, the racism and the stress involved, and the limited opportunities that even for things such as the death penalty, we just eliminating capital punishment. So we have this whole cloud of increased risk and stressors that are impacting our community.
Well, ladies and gentlemen, you're watching Rolling Out Health IQ, and we are in our last 15 minutes. So I really want to go around the horn one more time to talk about telemedicine and the revolution that will be televised. That's a little Gil Scott-Heron, y'all.
Can I say one thing about what Dr. McDougall said? Because we're like the dynamic duo. I'm so proud of the National Medical Association and all the work that they do. And I do believe that the individual determinants of health are really important. And the thing he was also pointing to are the social and political determinants of health. And if people don't know, your zip code is a stronger predictor of how long you can expect to live and the quality of life that you can expect to live than your genetic code. So zip code is more influential over your life and your health than your genetic code. And if you were to say, Deborah, what do you think are the 3 things we should do from a public health lens? I agree with everything that Dr. McDougall said. And when he's looking a patient in the face, that's what he should be saying. Quit the smoking, limit your drinking, cut the salt, eat the healthy diet, physical activity, all of that. As a public health person, I think 1, we need living wages living equitable wages for people. We know that when people have earning power, they also have the learning power. Now they get to exercise, right? Because one of the issues is, unfortunately, bologna is cheaper than salmon. You can feed a lot of people on a pack of bologna, and you ain't getting but one meal on a nice fresh piece of salmon with all those good omega-3 fatty acids and all those other things. I think people need safe and supportive environments that have good housing stock and that are food secure. I live in Flint. The nearest food outlet to me is the Family Dollar. And I go into Family Dollar and I watch people do their weekly grocery shopping at the Family Dollar. So any fruits and vegetables are coming out of a can, which are high sodium, high sugar, etc. So I think people need to live in safe and supportive environments that are safe to live in, safe for them to engage in outdoor recreation, things like that. And then the last thing is, I think we should make racism, when it can be proven, a crime. It should be a crime to enact racism on others. It should be a crime to use your power and privilege and authority to suppress another solely based on their skin color. And I think a lot of the stress and strife that Black people face, we talk a lot about hypertension, but we don't link it to the tremendous amount of stress that people have to endure for no other reason than being Black. If we started to disincentivize and criminalize racist activity, then I think we could turn that tide, and perhaps we would then have some kind of level playing field contextually for where Black people and brown people live and experience life, where I would feel more comfortable than holding them to account for their individual behavior. But we're just swimming in disadvantage. Even if you're wealthy, even if you have some degree of privilege, you can't get away from the additional tax and toll that being Black has on your health. So those would be my three things.
And even now, this administration is trying to deconstruct the Fair Housing Act of 1968.
Clearly, they put a physician in as the head of public housing. I mean, this is like one of the most basic fundamental necessities and rights that people have in America, to live in safe and supportive housing. And the role that public housing plays is not to be trivialized. And this is just the era of the unqualified and the incompetent. So if you really want something to degrade, you starve it. If you want something to not move forward and succeed, you put somebody who is incompetent. Now, if I had twins that were born conjoined, I would absolutely have Dr. Carson and ask him to be right at the front of the surgical team. He has no business heading the organization and the federal organization that organizes and funds public housing. It's the right man for the wrong job.
The mic drop yet?
Yeah, I'm sorry. I know he said he ain't gonna have me back, but that's okay. That's okay. That is okay. I've been thrown out of better Zooms than this.
I bring you back so we can go at it.
I want to go at it.
I bring you back so you can tell the truth. I don't bring you back that you ain't telling the truth. I'm gonna let you stay at home. You know, you gotta uplift and uprise. Come on now. It's not, if you're not part of it, that's a problem.
Before I really drop the mic, real quick, I'm gonna do this in 30 seconds and then I'm gonna shut up, I promise, is we need to link this to money. Dr. McDougall talked about health equity. I'm gonna give you just a 15-second example. During COVID, the federal government rolled out all this money for COVID testing. What they didn't do is say the people who benefit from this money, the people who benefit from this testing, have to be the people in the community that you are charged with serving. So what we found that happened in many communities is the people who benefited from that testing were the people who had access to transportation, the people who could get there, the people who got the word. Many of them already had other health insurance. There was nothing inequitable built into the money, but there was no assurance of equity attached to the money. So what I always say is our natural drift is to inequity. That's our natural drift. You could take the most fair, reasonable human service activity. If you don't build equity into it, how it will automatically, naturally play out is inequitably. So that money should have had attached to it a criteria that says the community that benefits from this has to mirror the medically underserved population that your federally qualified health center serves. I always say my love is unconditional. My money, my time, my attention got all kinds of strings attached to it. But we roll out money for healthcare with no strings attached. We need to start to attach equity to the money. People will figure it out. Those federally qualified health centers would have figured out how to make sure that they reach the most vulnerable. But because that wasn't a requirement, it just went how it went. We've got to build and attach equity to the money. Okay, and now I'm gonna stop. Thank you for having me.
Dr. Colbert, you got 2 minutes. I'm sorry.
No, that's a tough act to follow. That's really everything that needs to be said. I think, the only thing that I would add is that we have to ensure that telemedicine is here to stay. Because right now, a lot of telemedicine and all of the increased access to telemedicine is related to the CARES Act. And the CARES Act is around COVID. And as soon as those CARES Act funds are eliminated and the crisis has moved on, we have to hold the insurance companies accountable. We have to hold Medicare and Medicaid accountable to continue to provide access to telemedicine. And that's going to be part of the revolution. Are you willing to do something when it's not required, right? Keeping people safe during COVID right now is because people would not go to the doctor otherwise. When it's more comfortable to go to the doctor, when it's safer to spend time in a waiting room, when I can go into a hospital setting and not feel concerned about being exposed to coronavirus, and we have a vaccine and we've moved on. Are we going to go back to our old ways, or will we continue to move and push telemedicine forward? I think that's where we have to have significant activity and response. And really, I think the revolution is going to be in continuing the path that we're currently on and not reverting back to our former ways.
Mm-hmm.
All right, take us home, Dr. McDougall, and you've got 2 minutes.
Well, I just want to thank you and AARP for convening this session. Black people, communities of color are receptive to telemedicine, telehealth. It's an important extender of care, especially for those who have transportation issues. And it can be interspersed between in-person visits and the for greater communication and greater out. And so it's a wonderful opportunity, just as Dr. Colbert said, to continue this, continue building on this access and not let this go by the wayside.
Well, I want to thank all three of you for a phenomenal session. I hope the community, I want to thank AARP for powering this voice and this conversation to move forward. And I want to thank all of you three for being dedicated to eliminating the health disparities, to being dedicated to the underserved, and to also be innovators in delivering this new manifesto to our community. I mean, we really need to approach holiday in a different way. I think we've got to go a little bit deeper. I know when you say no sodium, but I think we really have to say to our community what that means. I think it's really a list, and I want to work with you and Dr. Holden and definitely my diagnostics when it comes to COVID. But I really want to make sure that we come away with some KPIs by February. I'm not sure what we can do with holiday, but I think we should have some reset. And I think that we really should have a Fitbit or some type of option that healthcare and insurance guarantee that people have, so that we can move that forward. because a person can move themselves forward with the right kind of conversation. So thanks again for tuning into Health IQ. We want to thank Dr. Colbreth. We want to thank Dr. McDougall, and of course, our sister in the struggle, a true healthcare and public health expert, Deborah Verholden, for tuning into Health IQ. Thanks, AARP. We love you guys. Thank you.